Good morning, USRNs. Today we will talk about genitourinary function or genitourinary disorders. We will talk about kidneys. This is the main organ of our genitourinary system. What are the functions of kidneys? Kidneys filters and remove waste products. Kidneys they are to remove waste products through glomerular filtration rate, fluid and electrolyte balance, vitamin D activation for bone health, acid-base balance related to HCO3, BP regulation, nandyan yung mnemonics ng RAAS, and activates erythropoietin. Number one function of kidneys is to filter and remove waste products. We need to remember the creatinine normal level, which is 0.6 to 1.2. Again, creatinine normal level is 0.6 to 1.2. This is a sensitive indicator of kidney damage. And on the other hand, we have the BUN, blood urea nitrogen, normal level that is 10 to 20. For glomerular filtration rate or GFR, this is the capacity to remove waste products. Normal GFR level is 90 to 120. Third function of the kidney is fluid and electrolytes balance. Fourth function is vitamin D activation, also found in bone health. We also have acid-base balance as the fifth function related to HCO3. Again, the sixth function is BP regulation, and the seventh function is that it activates erythropoietin or RBC production. Okay, so for the anatomy and physiology of kidneys, the kidneys are composed of distinct part. We have the renal cortex and the renal medulla. That's the renal parenchyma. For the cortex, ang mga hormones na nandyan kay cortex, nandyan si cortisol, aldosterone, inner cortex, and nephrons. However, on the other hand, medulla is the outer layer of the kidneys, kung saan nandyan si blood vessels, where epinephrine is produced. That's gonna be for vital signs regulation, si medulla. Nandyan din po si norepinephrine, which is BP regulation. Again, epinephrine is vital signs regulation, and norepinephrine is for blood pressure regulation. For the basic unit of the kidneys, we have nephrons. Parts of nephrons are tubules, glomerulus, and the Bowman's capsule. Si tubules po, nandyan po si urine formation. Important parts of tubules are loop of Henle, targeted by diuretics, or where the site of diuretics is, to prevent reabsorption. Okay, now we will talk about RAAS or RAAS. This is for BP regulation. It stands for renin, angiotensin, aldosterone system. Now, paano siya nagwo-work? Okay, there will be some triggers like brain detects hypotension if blood pressure is less than 90/60. Now the brain will activate the kidneys. The brain will tell the kidneys, hey kidneys, can you release renin please? The kidneys kidneys will say, sure. The first step of renin is into the liver, and the renin will become angiotensin 1. The second step of the renin is in the lungs, and angiotensin 1 becomes angiotensin 2. Angiotensin 2 is a vasoconstrictor. After that, angiotensin 2 will tap the adrenal gland. The adrenal gland will then activate the adrenal medulla, and norepinephrine is activated in the medulla. Norepinephrine will increase the blood pressure. On the other side, angiotensin 2 will tap the adrenal gland, and the adrenal cortex is activated. Diba si adrenal cortex and si adrenal medulla, those are the components or distinct parts of the kidneys. After adrenal cortex is activated, it will activate aldosterone. Aldosterone will also increase the blood pressure. When converting enzymes or ACE inhibitor, which stands for angiotensin converting enzyme, through potent vasoconstrictor, it goes back to renin becoming angiotensin 1, and it will go back to the same process. So again, it triggers the brain will activate the kidneys will release renin. The first step of renin is in liver, and renin becomes angiotensin 1. The second step is lungs, and angiotensin 1 becomes angiotensin 2, which is a vasoconstrictor. Vasoconstrictor meaning the angiotensin 2 will tap the adrenal gland and will tap the adrenal medulla and the adrenal cortex. Sa adrenal medulla, norepinephrine is activated, while in adrenal cortex, aldosterone hormone is being activated. Both norepinephrine and aldosterone will increase blood pressure. For our blood pressure, we have associated medication. The types of antihypertensive medication are ACE inhibitor. Ito yung mga gamot na merong prils sa dulo. Prils. We also have the angiotensin receptor blockers or ARBs. Mode of action for ARBs is it targets the blood pressure. So again, those medication for antihypertensive would be ACE inhibitor ending in prils, and angiotensin receptor blockers or ARBs. For example, if the heart rate is 102 and the blood pressure is 160/90, we need to give ACE inhibitors and ARBs. Another types of medication are beta blockers. Beta blockers naman, those are the medication that ending in olols. Beta blockers, olols. And calcium channel blockers, which targets the heart rate. We have verapamil, which is a calcium channel blocker. We have dipine, those medication ending in dipines. And another example is diltiazem. Again, beta blockers and calcium channel blockers, it targets the heart rate. For example, if the heart rate is 60, blood pressure is 150/90, that would be under ACE and ARBs. Pero pag sa heart rate, if it's too much heart rate, 110, pero less blood pressure, 90/60, we can give beta blockers and calcium channel blockers. So always remember, kapag sa medication for blood pressure and heart rate, For blood pressure management, we have the ACE inhibitors and ARBs, 2 ACE. And for the heart rate, we have beta blockers and calcium channel blockers. Ito yung merong mga blockers, beta blockers and calcium channel blockers for the heart rate. Now, let's begin to talk about kidney disorder. The first kidney disorder that we will talk about is the acute kidney injury. Acute kidney injury is reversible. The cause of acute kidney injury is pre-renal and intrarenal and post-renal. Pre-renal, intrarenal, and post-renal. For pre-renal acute kidney injury, this is a condition before reaching to the kidneys. Example, myocardial infarction, dehydration, shock, burn, uncontrolled blood pressure, diabetes mellitus. So those are the conditions before reaching to the kidneys. Intrarenal, these are the conditions within the renal parenchyma. So nakapasok na siya sa kidneys. Nandyan po si Will's tumor, which is pyelonephritis and nephrotic syndrome, and SLE, which means systemic lupus erythematosus. And the third acute kidney injury cause would be post-renal. This is after the kidneys are being affected, or this is outside the renal parenchyma. Nandiyan na po si urinary tract infection, BPH, sexually transmitted diseases, kasama po dyan, and kidney stones. Alright, that was for our acute kidney injury. Now, for acute kidney infection, this is also reversible. Meron tayong phases of acute kidney failure, acute kidney infection. We have the oligoric phase, diuretic phase, and recovery phase. CODR. Okay, the first phase of acute kidney infection is the oligoric phase. Always remember the normal urine output is 30 cc or 30 ml per hour. The signs and symptoms of oligoric phase is fluid volume excess. Signs and symptoms of fluid volume excess is congestion, edema, periorbital edema, bulging fontanelle. The diuretic phase, the urine output is more than 30 cc per hour, which is termed as polyuria. Signs and symptoms, we had fluid volume deficit. Signs and symptoms would be dehydration and weight loss. So, see, oligoric phase and diuretic phase, they are opposite. Oligoric phase, there is fluid volume excess, and diuretic phase, there is fluid volume deficit. Kasi ihi ng ihi si pasyente. For the recovery phase, this is the convalescent stage. This is continuation of stability. So that was for acute kidney infection. Now we move to chronic kidney disease. If it's chronic, it must be more than 6 months. So from recovery phase from acute kidney infection, there will be a sudden decrease of urine output due to diabetes mellitus as evidence of sluggish blood flow. Now this will lead to kidney damage due to decreased oxygen supply and also decreased tissue perfusion. It goes to our acute tubular necrosis or kidney cell death. Chronic kidney disease is irreversible. So, ano ba yung nangyayari sa kidneys natin kapag we have chronic kidney disease? Sa chronic kidney disease, there are no kidney filtration. So kapag walang kidney filtration, there would be waste product retention. Because of waste product retention, it will increase creatinine and also increases BUN. Again, normal creatinine value is 0.6 to 1.2. Normal BUN value is 10 to 20. So kapag nag-increase si creatinine, it will lead to more kidney damage. Kapag nag-increase naman si BUN, there will be lost level of consciousness or altered level of consciousness. It will also lead to pruritus. It will also lead to uremic frost. It also leads to uremic fetor. Okay. Now, there are also series of kidney malfunction that will lead to no kidney no kidney filtration, especially if there would be fluid and electrolyte imbalance. So fluid and electrolyte imbalance will lead to series of kidney malfunction that will lead to kidney filtration. Fluid and electrolyte imbalance would also lead to fluid retention that will cause edema. If edema goes up to the heart, it will lead to congestive heart failure. If edema goes to the brain, it will lead to cerebral edema. If the edema will go to lungs, it will cause pulmonary edema. Fluid and electrolyte imbalance will also lead to hypernatremia. This is increase in sodium. It will also lead to hyperkalemia, that is too much potassium in the blood. Hyperkalemia, the signs and symptoms or the hallmark sign of this is tall peak T wave, which is dysrhythmias, which is an emergency. Fluid and electrolyte imbalance would also lead to increased phosphorus level. Anong mangyayari kapag there is an increased phosphorus level? It will lead to pruritus. Fluid and electrolyte imbalance will also increase magnesium. Kapag mataas ang magnesium, there would be deep tendon reflexes and oliguria. Sa deep tendon reflexes, it will decrease our respiratory rate. And for oliguria naman, it will lead to hypotension or decreased blood pressure. Magnesium goes with calcium. So kapag mababa si magnesium, it will also lead to hypocalcemia, which is risk for fracture. By the way, increased phosphorus level will also lead to risk for fracture. Okay, the management for chronic kidney disease would be dialysis. This is an NCLEX hot topic, so you need to focus on this one. Meron tayong types of dialysis. We have the hemodialysis and the peritoneal dialysis. We will talk about hemodialysis first. Hemodialysis, it uses a machine that needs access to the temporary axis or the central line axis. Example, into the intrajugular, subclavian, and femoral. You need to watch out for infection because it's near the urine site. And also watch out for bleeding. The purpose of temporary access is for emergency. Tips to remember for dialysis. There should be no drugs prior to dialysis. Can be a day before, but it should be not within hours before dialysis. There should be a care in fistula. There should be no extraction on the affected side. All medication should be given directly to the machine. No blood pressure taking on the affected side or kung saan nandun yung central line. Close monitoring kay patient during dialysis. Patient, never leave your patient. We have to pre-weigh the patient before and weigh the patient after the procedure. Most important. Bakit kailangan natin i-weigh si patient? To monitor if there is enough or right amount of fluid in the patient's body. Okay? Now, aside from temporary access, we also have arteriovenous access or AV access. Diba si temporary access, it's for emergency and we need to watch out for infection. Si arteriovenous access naman or si AV access, we have the continuation of dialysis. Ito naman, it's called permanent access, CAV access or arteriovenous access. Example, we have the AV fistula and AV graft. AV graft is the best access for diabetes mellitus patient. It's on the arms. It needs to be matured, which is 2 to 6 weeks. Sign of maturation for AV graft would be bruit and thrill sounds. Bruit sounds, throughout auscultation there is a whooshing sound. It's like a river. Bruit sound. And thrill sounds, shock-like or vibration sound. Complication for permanent access or arteriovenous access would be disequilibrium syndrome, especially if the patient is a first-timer patient. Patient will be at risk for a seizure that will lead to increased intracranial pressure. Intracranial pressure will lead to coma. Comatose will lead to death. Management for this equilibrium syndrome, we have the continuous renal replacement therapy or CRRT. Now we will talk about the second complication of permanent access. We have hypertension, leg cramps, and chills. We need to position the patient into reverse Trendelenburg. The second type of dialysis is the peritoneal dialysis. Dito we use catheter. Diba? Si hemodialysis, we use access towards our central lines. When it comes to peritoneal dialysis, we use we use catheter or the Thinkhoff catheter. Thinkhoff catheter. The site is 3 to 5 centimeter below the umbilicus. Si central line sa first type of dialysis, which is si hemodialysis, sa arm. Si peritoneal dialysis naman is 3 to 5 centimeter below the umbilicus. Step to follow for peritoneal dialysis, we need to fill, dwell, and drain. That's in order. Fill, dwell, and drain. Si fill, prep for dialysate. Components of dialysate, we have amino acid, electrolytes, glucose for diuretic effect, lubricant for compatible solution. Si dwell naman, this is the dialysis process. If it's a manual dialysis process, it'll take 30 to 45 minutes. If it's electronic, it will lead or it needs 6 to 8 hours. This is during sleep. Drain is the output and outflow. You need to watch out for cloudy, color fluid, it indicates peritonitis. Sa drain, kapag cloudy color ang output, it may indicate peritonitis or infection of the peritoneal fluid. If there would be no outflow during the step of drain, you need to position the patient side to side. Side notes tayo. Have you heard about the renin? Remember renin? Renin, the goal of renin is to make renin become a potent vasoconstrictor. Aldosterone is a hormone for reabsorption. For acute and chronic illnesses, for acute illness, it's less than 6 months or the condition is sudden. Kapag si chronic naman, it should be more than 6 months. Ileostomy, ito lang yung forever. Di ba sabi nila walang forever? Pero si ileostomy is forever. Watery stool, yun yung lifetime. Merong gagasgas sa kidneys. Yung white blood cells, ginagasgas niya yung kidneys. So, kapag si ileostomy, it's gonna be watery stool forever. Phosphorus and calcium is inversely proportional. Phosphorus and calcium is inversely proportional. For example, if there is an increase in potassium, there will be a decrease in calcium. If there will be a decrease in calcium, there would be an increase in potassium. So, there. I think that's it. That's it, pansit. Thank you for listening.